Welcome, everyone, to the Center for Global Development. I'm Amanda Glassman, a Senior Fellow and Executive Vice President here. Today, we're really pleased to host Dr. Edward Okeke. He's a Senior Policy Researcher at the RAND Corporation and also a faculty member of the Pardee RAND Graduate School. He's both an applied microeconomist and a physician with training in public health. I think that's a really unique background, and his research is in a space that we at CGD have worked on for a very long time, specifically how it is that systems work together, what incentives do providers face, and how does that make a difference for outcomes, health outcomes. And today he'll be talking about a really interesting paper that looks at the effect of adding additional physician resources into the health system in Nigeria and the difference that that makes for health outcomes. So without further ado, I'll turn it over to Edward, and thanks very much for joining us.
All right. Thank you, Amanda. Okay, so I've started sharing my screen. Hopefully everyone can see the slides. Give me a thumbs up if you can see it. Yes, excellent. Okay, so thank you for the introduction. I also tell people sometimes that I'm wildly overeducated. In Nigeria, we tend to value degrees, and unfortunately, I'm not paid by the number of letters after my name. If I were, I think I would be in the 1%. Okay, so this is a study that I'm really excited to to present, and thanks for the invitation. So this is joint work with lots of people, as you will see, but my co-author of this paper, Professor Issa Abubakar, is also a longtime collaborator of mine. He's a professor of public health based in Nigeria. Okay, so my screen is not moving. Okay, there we go. So one of the questions I get quite a bit is, how did you manage this? And this took a village, right? It took a lot of people, supporting and helping out to make this happen. So I think it's important to spend like a minute or so just acknowledging all of the different people that made this happen. I think some of those people might be watching. So to those of you who are watching, a big thank you. I'm not going to go through all the names. That would take more than a minute. But I do want to single out one person, Dr. Nnenna Ihebuzo. So this is the third bullet point. So she used to be a director at the National Primary Healthcare Development Agency. This is the agency that oversees primary healthcare in Nigeria. I would not have been able to do the study without her support. Unfortunately, she passed away in 2018. And so, never got a chance to kind of see the results of the work. And so I just wanted to mention her by name. She'll be missed. Okay, so let me start by kind of setting the stage. And motivating why I think this is really interesting and why I think this is really important. So expanded access to primary health care should lead to better health outcomes. That's intuitive, right? If you give more people access to primary health care, they should have better health outcomes. And there are a couple of recent well-identified studies in the US that have shown precisely this relationship. However, for those of us who work in developing countries, what we find is that very often that relationship breaks down. So in some of the work that I've done and some of the work that others have done, what we generally tend to find is that you expand access, you increase utilization. Somehow that doesn't seem to translate into better health. And one of the leading explanations potentially for this is low levels of quality. So there is a hypothesis, several scholars in this area have hypothesized, right, that quality is the missing link. So If you think about access on one hand and outcomes on the other, quality is the bridge that links those two. And like a lot of bridges and roads in developing countries, it's not in very good repair. So that's kind of where this is coming from. So as it turns out, there's been a number of studies that have looked at quality. And I think the overwhelming consensus is that the quality of medical advice in developing countries tends to be poor. It's very often deficient. And I can cite a number of different studies, but there's one statistic in particular, one study in particular that I will just share just to really paint the picture in your mind. So Jishnu Das, who has done a number of the papers in this area, did a study in 2012, at least the paper came out in 2012, where they sent around fake patients. So sometimes we call them standardized patients, but these are fake patients that they sent around to different providers. And what they found is that the correct treatment, so the fake patient goes and says, I have X. What they found is that correct treatment was provided only 30% of the time. 42% of the time, the treatment that was provided was either useless or harmful. So, I mean, if you stop and think about that, I think that is a really startling factoid, if you will. Now, this is not unique to India. I think part of what we know now is that this kind of finding has been reproduced across multiple countries and across multiple settings. So one question then that we've grappled with is, so what constrains quality? Why is quality so low? And there is disagreement about, kind of what the key drivers are. So what we know is that for some of the studies that have looked at this, again, almost across all studies, we find a similar result, which is that it seems that the healthcare providers, the vast majority of healthcare providers, are simply not very competent. They're simply not very good. So the question that has fascinated me for a while, and which we try to answer in this paper, is, to what extent are bad health outcomes the result of bad providers? So I'm going to be sharing the results of what I think is a really interesting and novel policy experiment. This was a study that we carried out in Nigeria. Nigeria is relevant as, one of the outcomes I'll talk about later is newborn mortality. And I think Nigeria is relevant for just that reason alone. Nigeria accounts for 10% of all newborn deaths worldwide. So in this policy experiment, what we did was we randomly selected some communities and we sent them a newly trained doctor. So I will use the term doctor, sometimes I'll say medical officer. So this medical officer was posted to the public health center serving the community. And the posting was supposed to last for about 1 year. I think it's hard to overstate the significance of this, right? This is the first time, to my knowledge, that doctors or primary care providers generally have been randomly assigned to communities. And the reason this is important is because random assignment breaks the link that generally exists between provider characteristics and patient characteristics. Okay, so we added a doctor. What we hoped to achieve, so the assumption we're making here is that doctors who have an MBBS, the MBBS is so this is equivalent to the MD in the US. So the assumption is that, they're better trained, so they're going to be higher quality, so they'll deliver better care. Those are the assumptions that we're making. So we're interested in the effect of quality. However, adding a doctor has another effect. So yes, it has a quality effect potentially, but it also has a quantity effect because you've added another body to the health center. So there's a quality effect and a quantity effect. And that quantity effect, if you think about it, like it's, it may be positive. That's what we would expect. So maybe adding an extra worker, losing some of the constraints in the health center and allows them, maybe to offer additional services or to increase the number of hours that they provide services, etc. But it could also have a negative effect, right? So there could be a disruptive effect of sending, bringing in a new person into the setting. So, the quantity effect is interesting by itself, even though we're interested in the quality effect. Now, other than the identity of the provider that we send to, so I guess I should say something. So in order to separate the quality from the quantity effect, we selected another group of communities and we sent them an additional provider. So we have one set of communities that got a doctor, another set that got a mid-level provider. So I will use the term mid-level provider or MLP quite a bit. When I use the term, I mean all healthcare providers who do not have an MBBS. So this includes nurses, community health workers, etc. Other than the identity of other than the type of provider that we sent to these two communities, everything else we held carefully the same. So the length of the posting was identical, the resumption dates were the same, they worked under the same conditions. We have a third group of communities where nothing happened. So we use them as a pure control group. So I think one of the nice things about the setup is it allows us to do two things. One is it allows us to isolate the effect of quality, which we're really interested in, but it also allows us to contrast the effect of increasing quality versus increasing quantity of healthcare workers. And I will, I'll discuss the findings. So this is what the design looked like. So think about it this way. There are three arms. One arm got a doctor, one arm got a mid-level provider, and the third group of communities got nothing. So that's the status quo group. 180 health service areas were selected to take part in this policy experiment. A health service area, think of it as a catchment area. So this is a group of communities served by a public primary health center. 180 took part, drawn from 5 different states, so 36 per state. And within each state, we randomized to one of the 3 arms. So this is another way to look at it. So these are the 3 groups that I'm talking about. So there's the doctor HSA, health service area. I will also use the term community or cluster, means the same thing. So you have the doctor HSA, the MLP HSA, and then the control HSA. This is what the situation looked like before the intervention. So care was provided in these communities, for the most part, by mid-level healthcare providers. And I'm using this icon to represent them. So this is what we did. For the doctor HSAs, they received a newly trained doctor. For the MLP HSAs, they received an additional mid-level provider. The control group, nothing happened. So I will tell you right now, I'm not going to click on it, but randomization was successful. So when you randomize, you want to make sure that characteristics are in fact balanced, and they are. If I have time at the end and somebody wants to see it, I'm happy to share those. Okay, so one of the questions you're then thinking is, where did the doctors come from? Okay, so this is where I'll tell you, how did we do this? So as it turns out, we leveraged, so there's a really unique government program in Nigeria called the National Youth Service Scheme. So think of this as a 1-year community service program. All Nigerian graduates, so if you graduate from a university or college, you have to do 1 year of community service. So after you graduate, you get a call-up letter, and then you are posted to a community in Nigeria where you're supposed to work for about a year. Doctors also take part in this program. The difference is that doctors take part not right after graduating, but at least so they must complete at least 1 year of postgraduate training. So that's the housemanship year. They must complete that before taking part in the program. So there were 60 clusters that were randomly assigned to get a medical officer. We were able to get doctors to 57 of them. So this agency worked with us to post doctors to the designated communities. At baseline, just to give you a mental picture, so these are newly trained doctors. They have about 2 years of clinical experience. The MLPs were recruited and posted by the state governments. So as I showed you earlier, this was done across 5 states. We partnered with the governments in each of those states to recruit and post these MLPs. And we were able to get them to all 60 of the assigned clusters. So let me talk just a little bit about the kinds of MLPs that were posted. So they were of 2 types. So as a group, they're community health workers or community health practitioners. One group were community health extension workers, they're called CHOOSE. So they have about 2 to 3 years of clinical training after graduating from high school. And then there were also community health officers. So these are a little bit more advanced. A CHO can work for a number of years, usually about 5, and then they can go back and do an additional 2 years of training to become a CHO. So these are registered primary healthcare providers in Nigeria, and a number of other countries use them as well. Okay. So in terms of the resumption dates, let me show that to you. So as I said to you, we try to hold everything else the same, including making sure that the provider's doctor or MLP started at roughly the same time. And so that's what this graph is showing. So providers were posted between February of 2017 and September of 2017. The olive bars are the MLP clusters, and the white are the doctor clusters. The y-axis is simply the number of providers posted in that month. So what I want to just show you here is that you can see that the bars are almost exactly overlapped, meaning that providers resumed at about the same time. Okay, so let me talk about the data. In order to track the effects of what we did, so the individual or the health outcomes come from a sample of pregnant women that we recruited. So at baseline, we recruited 10,852 pregnant women between March and August 2017. So approximately 60 women were recruited in each cluster or in each HSA. Why pregnant women? 2 reasons. One, keep in mind that the doctor was going to be there for only about a year. That's determined by the program. And so we wanted a population that had a high probability of using medical care over the period that the doctors would be there. And so pregnant women, because we know that they need prenatal care, they need delivery care. So that was one reason why pregnant women. But the more important reason is because we know that child health, particularly early in life, is very sensitive to quality of care. And I'll talk about this again a little bit later. So that's the reason why we enroll pregnant women. So we surveyed them twice. So we visited them during recruitment, and they completed the survey at that time. And then we returned to talk to them again about 3 months after they gave birth. And that's the end line. So when I say end line, that's what I'm referring to. So for those of you who are familiar with these kinds of things, you are thinking attrition. So we had a very good retention rate. We only lost about 2.5% of the sample, and this is not differential across groups. So I think one of the nice things about the study is, not that I'm tooting my own horn, but one of the nice things about the study is that we collected a really extensive range of data. And part of the reason for this is because I wanted to make sure that we would be able to kind of pin down mechanisms and be able to tell, a reasonably convincing story. So I'll go over this a little bit. I don't have time to go over it extensively, but I just want to mention it so that you're aware. So we visited each of the 180 health centers that serves the communities twice. We visited them once at the beginning of the intervention and once at the end. So that's T1 and T2. We also surveyed health providers in each of these 180 health centers. So in all health centers, we would pick a healthcare provider, we would survey them. Additionally, in health centers that received a new provider, we also surveyed that provider as well. Additionally, we conducted what are known as direct observations. So we had a medically trained person on the research team sit and observe patient-provider interaction. So they would sit in the consulting room and observe. They would say nothing, they would not interrupt, they would simply sit there and take notes. So we have really, really good data on the kind of care that was provided in these health centers. We have performance evaluations, which I think is really neat. So at the end of the study, when we visited the health centers, we asked the in charge, so this is the senior health worker that is responsible for managing the health facility. We asked them to conduct confidential performance evaluations of the provider that was posted there. So we have that data, and it helps us to add additional nuance about exactly what these people were doing and what happened in the health centers. And then finally, we have data on what I'm calling audit visits. So these were surprise visits that we made to each health center over the intervention period. On average, we visited each health facility about 3 times. So I will use most of this data to kind of tease out what's happening. So we have a ton of data. So what I've done is I've divided the analysis into 4 parts. And this kind of mimics the underlying causal chain. So we want to systematically provide evidence about each link in the chain. So the first question is, okay, so you've posted doctors to these health centers. That should have, so essentially you've increased supply, but we want to show that. But in addition to increasing supply, we're also hoping to increase access. So that's the first part of the analysis. What's the effect on supply and access? The second question then is, what's the effect on quality? So as I said at the beginning, the assumption is that these MBBS trained providers are, they receive 6 years of training in Nigeria compared to, 2 to 3 for some of these mid-level providers. So we expect them, we hope, that they will be more clinically proficient. And then, so we look at that. And then the next question is, okay, so yes, they're clinically proficient or they're better in theory. Are they also better in practice? Do they provide better care? We will look at that as well. The third question is, okay, so you've done all this. How did that translate into an actual change in the probability that a patient's care was now delivered by a doctor? So that's the third part of the analysis. And then the final part is, okay, what effect did this have on health outcomes? So there's a lot of analysis and a lot of results. So for those of you who have the time, please read the paper, because I will not be able to get to all of the results, but I'll just at least give you a taste of each of these. So here is what happens to supply. So for each figure, I will put in parentheses where the data is coming from. So this is drawn from the staff register at the health center. So when we visited at T1, which is the beginning of the intervention, we asked, we looked at the staff register. The question here is, did they have a doctor on staff? T0 is before the arrival of the doctors, T2 is end line. And so what we hope to see here, which is precisely what we see, is that the probability that there was a doctor on staff, the red lines represent the doctor clusters, the blue lines represent the MLP clusters, and the gray is the control. So you can see that the probability of having a doctor went from 0 to 1, essentially, almost 1, only in the doctor clusters, which is what you would hope to see. And then what was the effect on access? So I've shown you that they were there, T1 and T2, but that doesn't tell me anything about what happened in between, right? So how did this affect access? So here I'm using the data from the audit visits, and what I'm doing here is I'm saying, for each month of the provider's tenure, what was the probability that the provider was on sit? So during the audit visits, the research person would ask, is this provider around? And if they cited them, that they would say that they were present. So we noticed that, okay, so I should point out something. You notice that the tenure seems to be 10 months. Even though I said the posting lasted a year, that's because a month in the beginning and a month at the end, roughly, are devoted to program formalities, exit formalities at the end, and resumption formalities at the beginning. So they were effectively there for for 10 months. So this tells you that, yes, it was lower than that of the mid-level provider posted, but again, the physicians generally were there. What was the effect on quality? So here I'm now testing, okay, are they in fact more competent? Do they demonstrate higher levels of proficiency than the mid-level providers? The answer to that is an unequivocal yes. So here I'm comparing three groups. I'm comparing the medical officer, again, the red line, to the newly posted MLP, to the existing MLP. And I'm comparing them on, so we have extensive data. So we did this clinical assessment of all of these providers at baseline. And so that's the data that I'm using here. So we assess them on three domains: basic medical knowledge, management of emergency obstetric care, and just general outpatient primary care management. So this is a score, it's a percentage score out of 100. And you can see that the distribution for doctors is shifted to the right, meaning that they scored higher on every domain relative to the mid-level providers. So that's what this makes clear. So yes, they were more competent. So then the next question is, how did this, did this translate into better care? And there's debate about this. Again, the answer is yes. So this is the only equation I'll show you. Like what I just showed you, I'm comparing again the doctors to the mid-level providers to the existing, to the new MLPs to the existing MLPs. The data here is from the direct observation. So remember that I said there was somebody in the consulting room observing what happened. So we know that, care will vary for individual patients because of the individual's presentation, but you can compare, there are general metrics that you can use to summarize across all patients, independent of what they presented with. And that's what we've tried to do here. So for example, we can ask, did the provider carry out a physical exam? Did they make a diagnosis? We can assess the quality of communication between the provider and the patients. So that's what we do here. And there's a dashed line at 0, which would indicate no effect. Again, you can see that the point estimates from this regression and the 95% confidence intervals demonstrate, I think, very clearly, not just were they more competent, they also delivered better care. Now, there's a lot more data that I can show you, but this, I think, should make the point. So then the third part is, what happened to care provision, right? So to what extent did this change the probability that a patient or that an individual was now seen by a doctor? Here we are using data from these women's prenatal health cards. So the prenatal health card, we know, for each visit, which provider they saw. And the outcome here is, for this figure, is, did the woman receive prenatal care from a doctor? And again, I'm comparing the doctor clusters to the MLP clusters to the control clusters. And you can see, again, very clear result. The probability that a woman's prenatal care was provided by a doctor went up by about 20 percentage points. Similar finding when we look at the probability that there was a doctor present at the child's birth. That went up by about 7 percentage points. So now, the final question is, what effect did this have on health outcomes? So the outcome, the primary outcome of interest here is early newborn mortality. So we define two mortality outcomes. One-day mortality, which is the probability that a child that was born alive died within the first day. And then 7-day mortality, which is early newborn mortality, the probability that they survived or that they died within the first week. The results look very similar, so I will typically just show one and not the other. So why am I interested in, or why did we choose early newborn mortality as the primary outcome? Because we know that a lot of early newborn deaths are preventable. We know that. And we know that mortality, the probability of a child dying soon after birth, is strongly linked to the quality of care that they receive at childbirth. So that's the reason why we picked this as the primary outcome. Okay, so what do we see? Yes, the physicians were there, or the doctors were there. Yes, they were more competent. Yes, they delivered better care. Okay, so what did this do to health outcomes? Here is the answer. So we find that newborn mortality dropped significantly in doctor communities, but not anywhere else. So here I'm comparing average mortality in each group, and you can see that it went down in doctor villages. Here is another way to look at it. So here I am looking again at one-day mortality, and I'm looking at trends over time. So I'm averaging by quarter because mortality is rare, so I'm averaging for each quarter of birth just to make the estimates more stable. So I'm looking at, or I'm showing you 2017 quarter 3, quarter 4, and then 2018 quarter 1. And you can see kind of the same result. And I think this is a really, at least I find this graph to be really compelling. So in the first quarter, you can see that mortality rates were roughly the same. But over time, you can see mortality rates dropping only in the doctor-assigned clusters. It went up a little bit in MLP and control villages. Okay, so just to summarize, so if you're going to sort of go away with anything, here's what you should go away with. So mortality, newborn mortality, early newborn mortality decreased by between 6 and 8 deaths per 1,000 in doctor-assigned communities. So this represents something like a 21 to 28% decrease in newborn mortality. What does that mean? Let's put that into context. So we know that there is a mortality gap between rural and urban areas. The magnitude of this decrease in mortality would essentially eliminate the gap in Nigeria between births in rural areas and births in urban areas. So again, that's one way to kind of contextualize the effect. So we do a lot of additional things in the paper. And I put them up here. Maybe if there are questions at the end, I will be able to share some of those results. But I want to make sure that I leave a little bit of time to kind of discuss the policy implications of what we found. Mm-hmm. So I think what emerges from this study is perhaps two things. One, so we show that adding a more competent health provider into the mix led to measurable improvements in quality of treatment and measurable improvements in health outcomes. And this helps us to kind of think about the effects of substandard quality of care, right? So that substandard quality of medical treatment actually leads to preventable deaths. And that's part of what the study shows. One way to try to quantify that is, so we estimate, okay, how many lives were saved by the doctor intervention? And then we value those lives in terms of lifetime earnings. So how much potentially would each child that was saved earn over their lifetime? So when we do the math, it turns out that each dollar spent on a program like this in real life, assuming we got the same results, would generate about $5 in benefits. Okay, so let's talk a little bit about the implications. So I think there are several, right? So there is a debate about sort of quantity versus quality in healthcare in developing countries. In other words, should we be focusing on increasing quantity of healthcare consumed, increasing utilization? So for example, with cash transfer programs, etc. Or should we instead be focusing on quality? Is quality actually a critical determinant of outcomes? And you know, this is an ongoing debate. I think part of what this study shows, in a way that has not, you know, it hasn't before, is that quality is an essential commodity. So that's a term the Nigerians that are watching will recognize. So quality is super important. So I think that's part of the implication of this study. The second implication is, so there is a task shifting debate that has been going on for years, right? So we know that there is a shortage of doctor labor, of doctors in many developing countries. And one of the solutions, arguably the main solution that has been pushed, is we need to devolve tasks. So essentially we need to use more MLPs, more mid-level providers. I think what the study shows is that we may need to pump the brakes on that, right? Asking people to do something that they may not be trained to do has costs, has welfare costs. And I think that's part of what the study shows. And then I think the last piece is, so over the last decade or so, there's been a lot of momentum, right? A lot of interest in performance-based financing. Let us nudge health providers to do more of what they know. Let us incentivize them to exert more effort. I think the results here should give a little bit of pause, right? The only constraint is not effort. In fact, a primary constraint may be just low levels of competence. Because yes, you can ask or you can nudge a provider to do more, but what if they don't know a lot to start with, right? That's kind of what the study seems to show. Okay, and I guess we can talk about this perhaps during the discussion, right? So this raises questions, right? Okay, so how do we improve quality in these communities? So I think this study offers one way, right? More doctors is one potential answer to that. And I think that there are creative ways of using the existing supply of doctors to meet some of these needs. And there are several programs like this around the world. There's in fact a program in Brazil that's called the More Doctors Program that uses doctors that are trained in other countries, and then they use them to meet some of these gaps in underserved areas. So I think that's one model. But I think another potential answer is more intensive training for mid-level providers. I think that, so I have to caveat that by saying that the evidence about the effectiveness of these training programs is still, I think, up for debate. But potentially, I think that is another way to do it. Okay, so I'm going to stop here, and I'll leave my email address up in case someone wants to ask me questions later on. Thank you.
Thank you so much, Edward. I think everyone can see how important this study is. I think if we look to the antecedents to the study, they've looked at one piece of the whole causal pathway that you've been able to randomize and measure very rigorously. So really congratulations to you and the team for such interesting work. And we'll come back to the policy implications. But first, I'm going to turn it over to my colleague, David Evans, who's a senior fellow at the Center for Global Development, who works mostly on education issues along the same lines, but also sometimes in health. So over to you, Dave.
Thanks so much. And I, like Edward, am just sharing a couple slides. It's hard for me to overstate how important I think this study is. And I'm going to provide just a little bit of context and then some implications that occurred to me as I engaged this work, and some questions that I think inform what comes next. So, what the context in which this paper lands is this potential quantity problem. So we have years of studies that look at simple correlations between the density of health workers and various health outcomes. And the problem is there's so many things that vary with the number of health workers that it's really hard to know what to infer from these studies. I mean, obviously intuitively it makes sense that more health workers help, but it's just, this is, places with more health workers are richer places, and they have all kinds of differences. And so, that, we come into this without a clear answer, even to this relatively simple question. And the other is the quality challenge. And so Edward mentioned early on some very good work from India with mystery patients who show up and you see. So using, a slightly less rigorous method, using kind of, vignettes, I just want to sort of situate this. If you look across, for example, 10 countries, 10 low and middle income countries, as you see here, this is from the World Bank Service Delivery Indicators data. What you can see across a set of basic maternal and child health outcomes, the probability that in these vignettes that health workers would be able to give an accurate diagnosis and recommended treatment varies dramatically across countries and is not very high anywhere. So Kenya performs best across these conditions with just 2/3 of health workers being able to give an accurate diagnosis and treatment. And so, the reason I say there's a potential quality problem as instead of just a quality problem is that this work still doesn't actually get at the health outcomes, right? It says, okay, there's definitely an issue that health workers don't, know that, can't diagnose, but this doesn't actually, close the loop in terms of how big is the impact on outcomes. And we can see this is for the same 10 countries across the conditions that were measured. You can see the same challenge. Health workers are relatively good at diagnosing and recommending treatment for malaria, but outside of that, there's a lot of weakness. So, that brings us to today's paper. How much do these matter for health? And so with this innovative policy experiment, we see no clear impact of just adding quantity, a sizable impact, not just on process, but on actual health outcomes in terms of improving quantity with quality, right? Adding a doctor, not just a health worker who doesn't necessarily have all the knowledge. So a couple of things that I think it's worth thinking about. None of these are a critique of the paper so much as thinking about what we do with this paper. So the first is, how might we expect these elasticities of quantity and quality to differ at different points along the quantity-quality spectrum, right? So there's a lot of variation even amongst low and middle income countries in terms of how many physicians they have per 1,000 populations. The latest data I could find, Nigeria is on the low end of lower middle income countries in terms of physician density. You've got a lot of variation though. So one can imagine in places where there are just very, very few doctors at the lower end of low income countries, that the elasticity might be different. Likewise, Nigeria, if we look across, this is from the service delivery indicators, fares relatively poorly on quality of health workers. Whereas if if we were looking at Sierra Leone or Kenya, which, where health workers just perform a little bit better on vignettes, they have slightly better knowledge. How would we think about this quantity quality trade-off? A couple of other things that I would think about as and I agree with the implications of the study in terms of, pumping the brakes on some of our conventional wisdoms. One is how we might expect effort to change over time. So this is using, fresh medical graduates. We know from the paper that knowledge doesn't seem to increase over time. So one result is that, health workers who've been out for more time don't actually have necessarily more knowledge. But one possibility certainly is that effort might decrease over time, right? One's first year in a new posting, one might exert more effort and be present more. A second is monitoring. So the monitoring isn't very different across the groups. So this isn't a question of internal validity of the study. One of the things that one might think about is whether there's any difference in the quality, like what's happening in the monitoring visits. But then I think more importantly, if one thinks about a program like this being implemented year after year at scale, one of the biggest challenges with taking successful small programs to scale and implementing them over time is the quality of monitoring tends to drop over time. And so insofar as people respond to that, that could have an impact. So a last few thoughts, and then we can get into the discussion. So obviously, the big takeaway is that countries need more doctors or more knowledgeable health workers. I think one thing that's important to remember is that this isn't an immigration implication. I can see certain development partners thinking, oh, so we need to stop doctors from migrating out of country, which obviously I don't know for every country, but I do know some good evidence that we have from the Philippines was that more nurse out migration actually led to more nurses being trained at home and remaining at home. And so you actually ended up with a higher supply of skilled health workers as a result of this out migration. So I think it's just a caution about some sort of, taking a migration implication from this. And then I think the other is to think about the relative value of different potential investments. So one is attracting better individuals into the profession. So more motivated or people who have better, knowledge coming into the profession, whether that's through, salaries or improving working conditions. Edward talked about training people. So both we've got pre-service and in-service. I would agree, there's huge variation in this. And I've seen this with the teacher literature as well. There are lots and lots of disastrous programs intended to teach train health workers and teachers. So there are a lot of, when I say disastrous, I mean they invest a lot of money and we don't see any change in knowledge or, much less behavior. Now, that said, in both of these literatures, it is possible to train, it is possible to upgrade the skills of health workers and teachers, but it's difficult, and it's even more difficult to do it at scale. So it's just something, again, the takeaway from this, we have to be very careful, I think, not to say, hey, let's just pour a bunch of money into the kind of training programs we've been doing. And then this comes up in the paper, but I think also thinking about just the relative investment of health systems in setting up, pay for performance versus investing in making sure that health workers have, the best skills possible. And this is relevant, I'll just say, also in the DiGiorgio work that I mentioned earlier, which showed that, people talk a lot about absenteeism as one element of accountability, and that reducing absenteeism, in models actually improves health outcomes much less than boosting healthcare worker knowledge and skills. And so that's consistent with what we find here experimentally, much more rigorously. So a lot of questions, some real challenges in implementing policy, but this is a big step forward in terms of what we know. Thanks.
Thanks, Dave. Can I, we'll ask Edward to respond to a little bit of that, and I'll also pose some questions that have been coming in. But I wanted to ask you, Edward, what about the policy in Nigeria? You mentioned that this was like a youth service training program, that it was a one-year assignment. Is this something that will be extended? Does the modality change? Sort of what were the practical implications of your work for policy?
So, okay, yes. So I think it's important to say, and I apologize that I didn't say this more clearly. So this is an ongoing program. So this is a program that has been in existence, I think, since maybe the 70s. So in that sense, we didn't create the program, we just used or leveraged the program. So I think, yes, one of the implications of this is, if you are able to channel these resources to the places where they are needed, then this can have a huge effect, in this case, on health outcomes. I think knowing the program, so I took part in this program myself, right? And knowing the program, so something I didn't say is, it's a government program, and so, the doctors are subsidized. So they're cheaper. And so as you can imagine, in a country or in a setting where there aren't a lot of doctors to start with, right, there's a lot of lobbying to get an NYSC doctor. And so that opens the door to influence peddling and so on, right? So using myself as an example, I was posted to, and speaking about coming full circle, I was posted, and this was a long time ago, to one of the states that took part in this policy experiment. And so that you can redeploy, you can ask to be posted somewhere else because you want to, you want more amenities, you want the city life and so on, right? So I think that cuts both ways, right? So, anyway, so to your question about the program, the program is, continues to run. This may help the implementers, the agency, to see the value of making sure that doctors go where they're supposed to go, right? If all the doctors are in hospitals in the urban centers, you would potentially find different effects, right? Okay, so and Dave had some really great comments. I agree about many of the comments that he's made. So, for example, the paper speaks to what potentially would happen if you somehow were able to make doctors available in a setting where there are very few doctors, right? So the results will differ depending on kind of where you are on that curve. But yeah, so I'm just going to say to Dave, really great comments, really great comments.
Can I also ask you, because you also did a really interesting study, I think with your same co-author, on cash transfers um, for facility births. Is that right? Remind me.
Yeah.
You know, I mean, you can imagine, as you say, these things are jointly determined, but that you know, this effect size is so large. But do you have any thoughts on? You sort of said, well, let's take account of all of these elements. So when you talk about that rebalancing in general, do you have any specific recommendations for public policymakers in Nigeria? Sorry to push you.
I'm always very careful about making policy recommendations.
Come on, CGD.
You know, so let me speak to the question about cash transfer. So for those people who are watching and listening, there were two interventions in the study. So this was a really large study. A large component of this, or one of the interventions, was this primary care provider intervention. But nested within the study was this cash transfer experiment, in which you know, roughly half of the pregnant women in the sample were offered a $14 incentive that was conditioned on using prenatal care and giving birth in the health facility. So I think it's useful to kind of discuss both together, right? So what we found when we looked at the effect of cash transfers was we also showed that mortality went down. And when we, you know, so when we disaggregate the effects for, you know, communities that got a new doctor and communities that didn't, we don't, again, the caveat here is once you start breaking the sample into small subgroups, then you don't really have a lot of power to detect effects. But at least with that caveat, we didn't seem to find too much difference between communities that got a doctor and communities that didn't, which at first was puzzling. Because if we're saying that quality is sort of the missing bridge, you know, like, so it turns out though, that when you look at the effects of the cash transfer, it reduced mortality in utero. So we found that the probability that the woman miscarried the baby went down. We also found that the probability that the child was stillborn went down. But we found no effect of the cash transfer on mortality after birth. In contrast, when we so in the primary care or the doctor piece of the study, that is precisely where we find an impact, right? We find that mortality after birth goes down when there's a doctor, and I think that one can reconcile these things, right? So one of the cases we make is that, you know, in utero mortality went down, likely because women used more prenatal care. Prenatal care is less complex to deliver, right? So there are standard things that, you know, need to happen during prenatal care. And so the returns to scale may not be very high. In other words, even a mid-level provider can deliver, you know, good quality prenatal care. However, once you start getting to, you know, delivery care and what happens after that, that's where the competence or the proficiency of the provider matters, right? Lots of things can happen when a woman is giving birth, and a provider needs to sort of be able to recognize what's happening, be able to know, okay, what should I do, and so on. So I think that the results are not inconsistent. But, you know, my sense is that there is a place for both things, right? So on the one hand, there are margins that you can improve even if quality stays the same. Mm-hmm. But I think that there are other margins that will be hard to improve without raising quality.
Absolutely. And another really interesting part of your work is to sort of lay out the costs and benefits of such policies. You know, this really does look like a no-brainer versus some other uses of spending that we might see. For example, in a lot of, you know, training programs are great, but if we don't know that they work to improve quality, this is something we do know it works if it's deployed into the right place. So I think, anyhow, I'm so impressed by this work. It's really, really interesting. So some of I'm going to tell you what the comments are from our audience. A lot of them had questions about the way that you are observing quality of care. So let me read some of those to you and then turn it back to you to answer. So one issue was about physician absence and retention in rural health centers in general. You know, given the year-long deployments, you're not really examining that issue directly. But so if you have any reflections on, does, you know, you have the program itself that you were studying, but what does it mean for the rest of the way that the health system works? And then I guess the other question is, you know, the communities that the doctors are working in, does that have some relationship with some of the differences in outcomes that you see? You know, how much does that account for differences that you saw prior to controlling for all the other things going on? A question about referencing the DAS paper on quality of care. He and his colleagues also found that the public sector physicians, whether they were working in the private or the public sectors, really were the most knowledgeable, but that in practice did not apply their knowledge. So one question for you is, did you observe that in your study? Is random placement itself an incentive for good behavior, better practice? In many countries, positions in government, health, and education are obtained because of networks. We talked a little bit about this. And you know, how important was the random assignment in helping to improve the outcomes? I think what you were saying before is that it's pretty important. Maybe I'll turn it back over to you to reflect on some of those questions.
Okay. Yeah, so I think those are really good questions. So I've scribbled some things to myself. I'll try to answer the questions. Hopefully, they will sort of hit the target. Okay, so one question was about retention of doctors. So we know that is an issue, right? We know that, well, in certain areas, right? So we want to get doctors to underserved communities for the most part. And we know that keeping doctors there, these also happen to be places that, you know, don't have a lot of the, you know, urban amenities and so on. And so it might be difficult retaining someone there long term. But I think while I cannot speak to that with this experiment, I think there's lots of other work that is potentially useful. If I'm allowed to kind of just reflect, I think that one strategy that could be successful, and you know, I think there's lots of interesting opportunities here for research. But I think one strategy that potentially would be successful is temporary postings, right? So you don't want, or you don't expect a doctor to, or a primary care provider, regardless of qualification, to go and live in, you know, in a village, for example, indefinitely. That may be unrealistic, no matter how much you pay them. But I think one model that has worked is temporary postings, right? You can do something and you can take something for a couple of years, and then you can rotate out. So I think that's one potential strategy, right? There are, like I said, there's a big literature on this. You know, structuring the incentives right, making sure that you're compensating people for some of the hardships and so on, right? So there are ways to do this, I think. The question about differences in community characteristics. So I think that's part of the value of the randomization, right? So that we can say for certain, well, we can say with a high level of probability that there were no differences in characteristics between communities that got a doctor and communities that got an MLP and communities that didn't get anything. So we have the characteristics and we can actually compare them across, which we do, and we don't find any differences. So that is unlikely to be an explanation for what is happening here for the results that we found. The third question about, okay, so this was, I think, this was maybe the trickiest to kind of wrap my head around. So it is true that, and I think Dave made this point as well. So we observe these providers for a year. We can only speak to what happens in a year. It's true that if this were to go on for an additional number of years, the results might be different. Like that's not something that I can necessarily speak to. Now, I think maybe one of the points here is, to what extent are the results being driven by the fact that, this was a policy experiment, and so the providers were potentially, exerting efforts, etc. So I think that's true, but I think, so in terms of internal validity, right? The mid-level providers were also subject to the same incentives or to the same constraints. So that doesn't explain the difference in outcomes. Now, one argument could be that, well, maybe doctors respond more to monitoring, and so that's why you would see. So it's not that in other words, even if you expose them to the same level of monitoring, doctors are qualitatively different in how they respond, and I think that could very well be. And my response to that would be, make monitoring a part of any program that you're going to implement. I think that is an important component of it, right? You want to make sure that people are doing what you're paying them to do.
Exactly. So thank you so much. We've come to the end of our time. This has been a really interesting talk, and congratulations to you and the whole group that worked to produce the findings. And I hope we can have you back to talk about your other work soon too. So
Thank you.
Thank you. And thanks everyone for joining, and watch for more. Thank you.